Thanks again to Dr. Kawanishi and as well as Martin Wilkie for your presentations in the DOPPS and the PDOPPS section. And we'll move on now in the last 45 minutes to our CKDopps study of advanced CKD. I have the privilege to introduce our moderator for this section, who is Roberto Perquafijo, who here at Arbor Research is the CKDopps principal investigator, also professor of medicine at the University of Pontifica in Curitiba, Brazil. And Roberto, thank you.
Thanks, Bruce, and welcome everybody again in name of the CKDopps group and investigators. I wanted to start this by just acknowledging the participation of our country investigators in France, Brazil, Germany, Japan, and the U.S., which are the countries who are currently participating in CKDopps. With we do have at the moment about 11,000 patients recruited, and a variation in follow-up time in different countries, but definitely already a long follow-up enough to allow us to start conducting longitudinal studies and outcome-driven studies, which is really great. And some of this we're going to be showing today in our presentations. So again, this is a list of number of sites and countries participating. You see here the total number of patients that we are currently following up of 11,000 patients, which is really great to see CKDopps at this stage. Can I see the next slide, please? Here. So here's the agenda for our presentation today. We will have 3 presentations followed by a brief discussion. And with that, I wanted to introduce our first speaker, who is Dr. Murilo Guedes. Murilo is a physician scientist from Brazil. He just finalized his research fellowship with us at Arbor Research. He was here with us for 1 year and focused his research in anemia and iron deficiency related to outcomes. And with that, I pass the mic to Murilo, who's going to be presenting on recent findings in anemia and iron deficiency. Murilo, thanks for participating.
Thanks, Roberto, and thanks for the DOPPS team for the opportunity of working on this 2 projects I'm going to be presenting here. And thanks for the full team that worked with me throughout this year for those manuscripts. So currently, the presentation that I have for today is going to be presented as well as for ASN. As Brian noticed before, the QR code that you can see in the screen can lead you to the presentation in the actual Congress. So the first project I wanted to discuss here is as in its title, Iron Deficiency is Associated with Worse Physical Health-Related Quality of Life in Non-Dialysis CKD Patients with or Without Anemia. Next slide, please. So this first slide is a visual abstract that we put together as a general summary of our findings in the CKDopps study. And I take advantage while you take a look at this slide to provide some background for our study. So iron deficiency is prevalent in up to 35 to 45% of patients with non-dialysis CKD. And in spite of the high frequency, there is a few studies out there evaluating or exploring the associations of iron deficiency and patient-reported outcomes. As a background information, we know that iron, in spite of its erythropoietic effect, has an important role in muscle function. So we were interested in understanding how patients may feel or may perceive iron deficiency in terms of not only physical quality of life, but also mental components. And for doing so, as you can see in the general snapshot summary there, we use CKDopps cohorts to evaluate key outcomes in terms of patient-reported measures. The KDQOL-36 was the main scale we used, the physical and the mental, the PCS and MCS. And also we explore functionality, depression, and physical activity. For this study, we included patients from France, US, and Brazil. And you can see there the main findings for a study that I walked you through just now. Next slide, please. So in terms of more details for study design, we included, sorry, I think this slide is inverted. This is for the other study. This is for the clinical trials one. So if we can pass the slide forward to the other presentation, I think. Can we just pass? Yes. Go down a little bit. Sorry. Yeah. So I think the slides are repeated. Okay. So we can just go up there in the presentation. So back slide. Sorry. Yeah. So I'll just give a summary for this study, the previous study on the quality of life. So for that, if you can just get back to the visual abstract, just use that as a summary, and then we can go to the clinical outcomes. Yeah, thank you. So for this study, we included patients in CKDopps. So the mean eGFR was 30 ml per minute. Roughly 50% of them had heart failure, and the mean age was 67 years old. As you can see, the mean hemoglobin was 12.6, and TSAT levels were 26%. So as I was mentioning before, we used data from France, Brazil, and the US, and we captured the closest TSAT and ferritin to the quality of life measurement. The window we defined for this was 180 days. So the closest TSAT to the quality of life evaluation was used for that. In terms of exposures, we both treated TSAT and ferritin continuously, but also we classified it iron deficiency by absolute iron deficiency for TSAT lower than 20% and ferritin roughly lower than 100 or 50 nanograms per ml. And functional iron deficiency was defined as low TSAT lower than 20% and higher ferritin as higher than 100 nanograms per ml. Our main findings for this study were that for patients with both functional or absolute iron deficiency, they tended to have lower physical component scores, lower probability of having intense physical activity, and importantly, less functionality, particularly for those with functional iron deficiency. Those patients were more inflamed, as we tend to understand them clinically, so with the low iron stores due to iron restriction. As opposed to the mental component scores. So for this study, we found very flat associations between TSAT or ferritin with the mental components of quality of life, including the MCS from the KDQ Route 36, and also depression, self-reported depression was not, didn't have a strong association with quality of life. So as a summary, patients with low TSAT, as well as both patients with functional or absolute iron deficiency, tended to have lower physical quality of life, physical components of quality of life, as opposed to the mental component. And these findings, they suggest that tissue iron deficiency, as we just an important point, we use models both with and without hemoglobin to assess both the direct effects of iron stores and the non-direct effects, meaning that we adjusting by hemoglobin, you could assess the effect even among the subset of patients without anemia. So our findings suggest that even among those without anemia, iron deficiency drives or is associated to worse quality of life. And the main implication is that for non-dialysis CKD field, well-designed randomized controlled trials beyond or focusing beyond the erythropoietic-focused outcomes should be pursued for improving quality of life for those patients. So next slide. And this moves to our other study using CKDopps as well, and also as exposure for being the iron deficiency or iron store parameters. But for this evaluation, we looked at all-cause mortality and major adverse cardiovascular events. Next slide, please. So the same outline. We had a visual abstract for this work as well, in which we consistently use CKDopps Here, we included France, Germany, Brazil, and the U.S. And for this cohort, we included 5,145 non-dialysis TB patients, also with an eGFR of 28 ml per minute, roughly 15% of them with heart failure. For this study, we used as main exposure the TSAT and ferritin and study entry, as summarized in the visual abstract. We're summarizing the effects for TSAT lower than 15% versus those with 25 to 35%. Consistently, we used models adjusted and non-adjusted for hemoglobin other than the main confounders. And for those results, we tended to see that patients with low TSAT, here lower than 15%, tended to have not only increased risk for all-cause mortality, and this is pre-SRT mortality, but also for major adverse cardiovascular events. The findings we had were not affected either by adjustment for hemoglobin, as you can see there in the comparisons, but they were not also, we did not find any interaction by hemoglobin levels. Next slide, please. So for this study, and this is the study design that we're showing here. So we used the first TSAT and ferritin at study entry. These patients were followed roughly 2.5 years until their outcomes. Majority of included patients were French individuals, followed by Germany, U.S., and Brazil. Our primary outcome here for this analysis all-cause pre-SRT mortality, and secondary outcomes we defined the MACE, the major adverse cardiovascular events. For the MACE, we had a set of events that we used for the definition, more or less consistent with the cardiovascular literature, but importantly consistent with previous studies for this area, including the pivotal trial. For this study, we defined cardiovascular death, non-fatal acute myocardial infarction, non-fatal stroke, and heart failure hospitalizations as a composite MACE. As you can see, the overall mortality rate for this study was 4.7 per 100 patient years, and the MACE rate is 4.8. At the bottom of the slide, you can see a little bit of structural associations between the variables that we designed a priori. So we have the iron stores main exposures, and we pursue the associations with the outcomes that are just in the right, adjusting for the confounders that I'm going to speak in just a minute, but also adjusting for hemoglobin, which is the proposed mediator variable, as we know that lower hemoglobin is associated with worse outcomes from the previous literature. We made sure to capture hemoglobin at the same time as TSAT and ferritin, and we included models adjusted and non-adjusted for hemoglobin other than the confounders. Next slide, please. This is the sample characteristics. So, as a general idea here, stratified by TSAT levels, those patients with lower TSAT, they tended to be older, a higher proportion of female patients, and a greater proportion of comorbidities, as we expected. So, higher proportion of heart failure, more coronary artery disease, and more diabetes. In terms of iron prescriptions or anemia interventions, we tended to see that patients with lower and higher TSAT tend to receive more ESAs, and at the lower spectrum TSAT, more individuals were receiving iron, IV iron or oral. The associations with eGFR tended to be a little bit flat, as previously described in CKDopps, so not a big association between lower eGFR and TSAT in general. And as expected, naturally, patients with lower TSAT had lower hemoglobin. Next slide, please. These are the results. So these are forest plots showing our results. So each one of the numbers there in the cycles represents stepwise models. From model 1 to model 5, we have progressive adjustment for confounders. The difference between model 5 and model 4 and model 5, is the inclusion of hemoglobin for the adjustment. As you can see there, for all-cause mortality, compared to the reference of patients with 25 to 35%, those with progressively lower TSAT tend to have higher risk of all-cause mortality. And even after adjustment for hemoglobin, as you can see from 4 to 5, there was no big difference in the fact estimates. In fact, when we look at patients with 35 to 45%, we tended to see the lowest risk for all-cause mortality. And as TSAT goes down, the increasing risk tends to be continuous. as opposed to those with greater than 45%, in which we tend to see slightly higher risk. Next slide, please. This figure shows the interactions between TSAT and ferritin. In general, in the panel A, what you can see are the hazard ratios for each one of those points. They show the hazard ratios for combinations of TSAT and ferritin compared to the reference of middle point there of TSAT of 25% and ferritin 130 nanograms per ml. The color regions show the magnitude of the hazard ratio, being the red ones, the darker red, the greatest hazard ratios for that region, and the green ones are the lower. For panel B, what we can see is the p-values for each one of those regions, being the red region, the red and the orange regions, the p-value is lower than 0.05. In general, for the general message of this interaction is, first, we tend to see an interaction between TSAT and ferritin for all-cause mortality events. And in general, as we tend to go down with TSAT and high with ferritin, so those individuals with lower TSAT and high ferritin tended to be at increased risk of adjusted for main confounders for all-cause pre-SRD mortality. And this is very consistent with the effects that we saw for the patient-reported outcome study, in which individuals with lower TSAT and high ferritin, probably those with functional iron deficiency and iron restriction, tended to be at increased risk of adverse clinical events. Next slide, please. Finally, this shows the major adverse cardiovascular events. For this analysis, restricted for patients from Brazil, US, and France. And consistently compared to what we saw from the all-cause mortality events, as compared to the reference of 25 to 35% in TSAT, those with lower TSAT tend to be at increased risk of MACE, with hazard ratios up to 1.5. And with little effects, small differences after the adjustment for hemoglobin, as you can see, comparing model 4 with model 5. In fact, as we saw before, those with 35 to 45% tended to be at even lower risk than the reference group. And not as consistent with the all-cause mortality, individuals with greater TSAT did not tend to have as much risk for MACE events. Next slide, please. So in general, the take-home message for this work is that the patients with lower TSAT tended to have increased risk for all-cause mortality and MACE, even among those without anemia. Patients with 35 to 45% TSAT range tended to have the lowest risk, and those with lower than 40% in general had a continuous increased risk for all-cause mortality. We did find an interaction between TSAT and ferritin, and in general, the shape of this interaction showed that patients with lower TSAT and higher ferritin were at increased risk of adverse clinical events. And these findings are very consistent with previous literature, such as literature in heart failure patients, in which major randomized controlled trials have shown that iron therapy, even among those patients without anemia, improves clinical outcomes. So these findings taken together, they suggest that we do need to shift the paradigm in non-dialysis CKD patients by pursuing non-erythropoietic focused goals in new, well-designed randomized controlled trials, even among individuals without anemia in non-dialysis CKD. Yeah, that's my last slide. Thanks.
Thank you very much, Murilo. That was a very nice combination of two presentations. I might shift a little bit the way that we think about iron deficiency and potential for increasing the profile of patients that might benefit from iron therapies in the future. We are a bit behind schedule here, so I'll just shift to the next presentation. We'll take some of the questions later on if we have time, and it's my pleasure to introduce our second speaker, Dr. Manfred Hecking. Manfred is a professor of medicine at the University of Vienna in Austria and has been leading a very interesting project that he's going to be sharing preliminary results with you. It's a poster that will be presented at the ASN this year, and Manfred is going to be talking about sex-specific differences in clinical outcomes in patients with CKD. Manfred, thanks very much for sharing this nice study with us.
Thank you, Roberto. Thank you, everyone, for inviting me. I hope you can hear me. Otherwise, let me know immediately. Can I have the next slide, please? So the disclosures, this is a project that was supported by the Austrian Science Fund and thankfully by CKDopps, which has many sponsors. Next slide, please. I want to introduce you into the area of sex and gender. And I brought three examples from art, actually. And if you are from North America, maybe you know the play My Fair Lady. And in My Fair Lady, the famous song goes, "Why can't a woman be more like a man?" And that's actually the frustration of the lead character, that at the time, the song, very interesting story. The way it was they were coming up with this song is because Lerner, who actually composed the whole play, had marital problems. And they were discussing among Rex Harrington and Lerner in New York, their fourth and fifth marriage that they were going through. And then actually that's why they came up with the fact that if men were among men, then things might be easier. Where men aren't always among men. Another example here about sex and gender comes from Germany. Richard Strauss composed A Hero's Life. And the role of the violin is actually a tribute to his wife. And Richard Strauss himself, was the hero, and the wife is the companion. Now, something else is Edgar Degas painting young Spartan girls challenging boys. This is from the 19th century, maybe an analogy that sometimes men and women are afraid of one another. Can I have the next slide? In nephrology, I was fortunate enough to do a study in the DOPPS in the year 2014. We published something that's been well known before, that fewer women than men are actually undergoing hemodialysis. And here you see a couple of countries in the DOPPS. In the top rows, you always see the general population. The bottom rows, you see the HD population. The percent of females is always lower than the percent of males. And the next slide, please. Several explanatory hypotheses have been proposed to explain this. Don't worry if you can't read anything very clearly on the next slide that will follow. I want to talk you through. Next slide. Hypothesis one is that women have worse survival than men while they're on dialysis. Next slide, please. This is false, because we saw that the hazard ratio for the male to female mortality risk was always greater 1 in dialysis patients, depending on the adjustment, but it would never be below 1. Next slide, please. Hypothesis 2 is that there's actually fewer women than men that are affected by chronic kidney disease, and this is false as well. Next slide. Because in almost all countries of the world, more women than men have chronic kidney disease. Next slide, please. Hypothesis 3 is that fewer women than men actually are incident dialysis patients, meaning that they start with dialysis. This is true. Next slide. And this has been shown in about all of the countries in the world. And hypothesis 4 is that the rate is historically inconsistent, and this is false. Hypothesis 4 was born out of this question of the lucky 13 survivors of hemodialysis who were being dialyzed by Stanley Sheldon. And you see that 2 women were in this picture. They were sitting next to the medical doctor, and all the others were males. So we were thinking, next slide, please, that historically perhaps there was an inconsistency in the percentage of women versus men initiating dialysis. This was not true. Over the last 5 decades, the percentage has always been 40 to 60. Next slide, please. So what is the fate of individuals with CKD? It actually differs by nephrologist referral. Next slide, please. So an individual with eGFR smaller than 30 can be referred to a nephrologist from where he may be dying or initiating dialysis. Next slide. Or he can be not referred to the nephrologist. And we are actually now concerned with those that are referred to nephrologists, because that's who we capture in CKDopps. Next slide, please. So the aim in CKDopps was to assess sex-specific differences in clinical outcomes among individuals with CKD. Next slide, please. Basically, to get rid of this left part of the picture that I just showed you before, but those that are referred to the nephrologist, the lucky ones that get to the nephrologist, what is happening to their fate? And the unlucky ones that are not to the nephrologist, there can be something different happening. Next slide, please. So what we did is we used CKDopps data from about 8,000 patients, participants from Brazil, France, Germany, and the US. We had cumulative incidents in them, and we conducted fine and gray models adjusting for age, African American race, but most importantly, eGFR slope in the first 12 months after enrollment. Next slide, please. The first thing that we were amazed to find, next slide, please, is that there were more men than women in the CKDopps. I showed you a slide before that more women than men have CKD, but in the CKDopps population, there are actually more men. And the marital status is a bit different among them. So in general, more men than women are married, which has to do with the fact that more men than women are also, less men than women are divorced, and more women are widowed. Next slide, please. It becomes a bit more interesting when you look at the eGFR at the entry into CKDopps. It's a bit higher in men than it is in women, and there are more women than men throughout the later stages. So among those with pre-dialysis stage 5, there's more women than men. Next slide, please. Next slide. In the CKDopps population, men actually have more vascular disease, peripheral vascular disease, but also coronary artery disease. Next slide, please. And men also have more albuminuria than women. Next slide, please. Next slide. eGFR at dialysis initiation is a bit higher than in men than it is in women. But interestingly, the percentage of late dialysis initiators is consistently higher among women. It's 5% versus men, 3%. Can I have the next slide, please? So now we're getting to the hot stuff. We're going to the cumulative incidence of dialysis, transplant, and death without kidney replacement therapy and kidney replacement therapy-free survival. Next slide, please. So here you see these cumulative incidence curves. Next slide, please. And I'm showing you here the adverse event rates per 100 patient years. Next slide, please. And here you can see the pre-kidney replacement therapy death. And you can see that pre-KRT death is a bit higher in men than it is in women. And next slide. But kidney replacement therapy is much higher in men than it is in women. So the quota event of kidney replacement therapy is 8.3 per 100 patient years in men versus 6.8 in women. Next slide, please. Next slide. So if we look at the hazard ratio of male for dialysis, transplant at all cause pre-KRT death in 3 years of follow-up, you can see that actually, yes, the male to female ratio of pre-KRT death is shifted to the disadvantage of the men, meaning that the men, they die more. But the advantage of dialysis, being placed on dialysis, if you wish, dialysis being an advantage, it's much more prevalent in the men. And the HR, male to female, is about 1.4. And the interesting thing is when you adjust this for eGFR slope, meaning eGFR progression, the HR, male to female, goes up a bit more, meaning that a slower progression among women would not explain this phenomenon. So we have an HR about 1.5 shifting to 1.6 or 1.4 shifting to 1.5, depending on the model, for kidney replacement therapy initiation, male over female. Next slide, please. In summary, despite the well-known higher CKD prevalence in women, more men actually receive treatment at nephrologist-led CKDopps clinics. And I just want to make you aware of a publication that we've submitted where a student of mine looked into CKD awareness, the awareness of weak or failing kidneys, answering yes to that question in the ENHANCE program. And CKD awareness is higher in men than in women. Throughout all the years and periods that were studied, all the women are catching up a bit. Next slide, please. So reasons for what we saw that men had a higher chance of commencing dialysis before death, and that was unexplained by CKD progression. This finding helps interpret the preponderance of men in the dialysis population. But what are the reasons behind this finding? So you might think that symptom burden is lower in women, but that is false. That was nicely shown by a paper by Monique van der Looijengarten with data from the EQUAL study. Symptom burden is almost every part of symptom burden is worse in women than in men. Next slide, please. Another reason could be that women may be lacking a caretaker. The stereotypical gender roles, and I introduced a couple of pictures at the beginning, to let you just look into these stereotypes. And sorry that I didn't include any other country than European and English-speaking ones or French-speaking ones. Alison Tong from Australia is leading a project here in Vienna, and she has finished a paper where she conducted clinician interviews, and these clinician interviews in clinicians caring for CKD patients, they actually confirm that there are a lot of stereotypes still, and that this hypothesis that women may be lacking a caretaker more than men is true. Next slide, please. So do nephrologists actually make gender bias decisions? We don't know. We are looking into this. We are conducting other studies. But be aware of this paper by Sarah Davis, and it's been published a long time ago, answering the question, who makes the decision to initiate dialysis? In over 50% of the cases, it's the doctor's decision. This was a survey answered by patients. So next slide, please. I'm very, very happy to hear your thoughts and to discuss other reasons for the findings that we saw in CKDopps. We are actually eager to await results from the general population that we are looking into with JJ Carrero from Karolinska Institute and SCREAM. Thank you very much, CKDopps, for helping us with this project, and hopefully we have some more coming up soon. Thank you.
Thanks very much, Manfred, for this very interesting and I would say provocative presentation about sex differences in dialysis and as an outcome. We will proceed to the next presentation, and then we'll take some of the questions later on if we have time. And so with that, I'll pass to the last presentation on CKDopps, which is actually a CKD specific presentation, meaning based on the CKD data. This is going to be done by Victor Fage, is a recorded presentation, and Benedict Stengel, who's the co-chair of the CKDopps steering committee and the principal investigator of CKD is going to be here after the presentation to answer any of your questions. So I'll just pass it to Victor.
Hello, my name is Victor Fage. I am a French resident in nephrology. Thank you very much for inviting me to discuss about my project on urgent start dialysis. When we look into the literature, we can see that various definitions are used to qualify dialysis start. We can find emergency start, unplanned start, or suboptimal start that can define different things, such as in-hospital start or start with an intravenous catheter. This definition of urgent start has been clarified by a KDIGO conference in 2018, and it is now defined as in patients in which dialysis must be initiated imminently or in the 48 hours after presentation to correct life-threatening manifestation. In France, The rate of urgent start dialysis is stable in the last 15 years, around 30%. This rate is based on data from the Rhin registry, which uses a definition close to KDIGO guidelines. The objectives of our study were to estimate the risk of urgent start before and after reaching CKD stage 5, to study determinants of urgent start dialysis, with a special focus on social factors and patterns of care, and to compare reasons and dialysis modalities between our two groups, urgent versus non-urgent start patients, as well as mortality within the first 3 months. This study included 3,033 patients with an eGFR below 60 ml per minute, a mean age of 67 years old, 65% of men, and a median nephrology follow-up of 4 years. Between enrollment and January 2020, there were 402 patients that died before reaching dialysis or transplantation, 84 patients had preemptive transplantation, and 501 patients started maintenance dialysis. To ascertain dialysis start status, we used a combination of two CKDopps variables, initiation of dialysis urgent versus planned, and dialysis start in hospital, as well as a variable from the Rhin registry, urgent start dialysis, yes versus no, which was obtained by record linkage between the two databases. In case of inconsistency between those variables, we checked medical records to find the dialysis initiation reports. By combining these variables, we reduced the number of missing data to 40, and we classified 86 dialysis starts as urgent starts, which represents 16% of our dialysis patients. We estimated the 5 years competing risk of urgent start dialysis compared to timely kidney replacement therapy and death, and we found that dialysis start, whether urgent in gray or non-urgent in red, were uncommon before reaching GFR below 15 ml per minute. They represented less than 2% of patients. In patients who had reached CKD stage 5, 2 out of 3 started kidney replacement therapy timely within 2 years, either through preemptive transplant or non-urgent start dialysis, while 7% of patients experienced urgent start dialysis. The reasons to initiate dialysis are reported in this figure. Different reasons could be reported for a single patient, and we compare the reasons reported between our two groups, urgent start in dark blue compared to non-urgent start in light blue. As we can see, worsening following surgery, hydroelectrolytic disorder, and we can think especially about hyperkalemia, fluid overload, and AKI were all significantly more frequently reported in the urgent start group compared to the non-urgent start group. Patient-related factors associated with urgent start dialysis included an older age, loneliness, and poor literacy. Missing nephrology visits in the last year before dialysis and refusing dialysis tended to be higher in urgent starters, but the association was not statistically significant. CKD-related factors associated with urgent start dialysis included diabetes, heart failure, and other cardiovascular disease, as well as polypharmacy. Hemoglobin level and eGFR levels, however, did not significantly differ between our two groups. Finally, service-related factors associated with urgent start dialysis included a lower number of nephrology visits in the year before dialysis initiation, a lower attendance to KRT education, and higher percentages of unplanned dialysis modalities and of planned conservative care. In multivariate analysis, living alone, low literacy, heart failure, and polypharmacy were all independently associated with higher odds of urgent start dialysis, while planned dialysis modality and a higher number of nephrology visits were significantly associated with lower odds. Of note, after adjustment for these factors, age was no longer associated with urgent start. Regarding dialysis modalities and mortality, 32% of all dialysis were initiated by an unplanned hospitalization. It was in 100% of urgent start cases and in 15% of non-urgent start. Only one patient started peritoneal dialysis urgently, although 10% of urgent start patients had planned this modality during follow-up. Regarding dialysis access, 52% of all patients started with an AV fistula or a graft, but this percentage was 29% in urgent start patients. As expected, mortality within 3 months was much higher among urgent than non-urgent starters. It was 4 times higher. To conclude, urgent start dialysis remains an important issue, even among patients under nephrology care, as we saw that the rate of urgent start in our study was 16%. We described new determinants of urgent start, such as polypharmacy, patients living alone, the intensity of nephrology care, and the poor literacy, which is still probably poorly assessed in clinical practice, despite the complexity that represents a chronic kidney disease. Thank you for your attention.
I wanted to thank Victor for the presentation. Victor is not present today for a very good reason. He's in his honeymoon. He got married last week, and Benedict is here to take over some of the questions. I'll start with a question to Murilo from a previous presentation. Murilo, there's a question in the chat asking about the adjustment for iron therapy in your models. Did you adjust it, or was it something that was not considered in general?
Yeah, that's a great question, Robert, and thanks for this. For the models we presented, we did not adjust for iron therapy. We did discuss this adjustment while we were planning these analyses, and we decided to not adjust for iron as we did not consider it a potential confounder for this particular association.
Thanks. And Benedict, I hope you're hearing as well. I was impressed about the impact of heart failure in the urgent dialysis starts. And I think it's very interesting because it probably means that this subgroup of patients might have a different evolution in terms of GFR decline. Is that your understanding too?
Yes, it's heart failure has really been. Do you hear me? Yes.
Yes, very well.
Okay. So heart failure has been identified for a very long time as a risk factor for urgent start dialysis. I mean, it has been shown in all studies. Either patients who were early referred to nephrology or those who were lately referred. So probably you're right. The management of heart failure is complex, and probably the management of the volume management is probably complex also in this patient. Yeah. And this is one of the most frequent reasons to start dialysis urgently.
Yeah. And another question from the chat, Benedict, is about the GFR at the start of follow-up in both groups. Was it different or adjusted?
Yes, it was different. But what was really interesting, and this is really something that I want to point, is the KDIGO definition. The KDIGO Consensus Conference definition really made a difference between urgent dialysis start and dialysis start urgent versus non-urgent, and also modality planning, yes versus no. And what is interesting is that you can have, in those who had urgent start, you have a lot of patients who actually had a functional fistula or a graft, and who actually had a dialysis modality that was planned. So obviously, less of urgent starters had a modality plan, and less of them had a functional AV fistula. But if I look at them, I think it was shown, but I can't find it. I'm sorry, where is it? Sorry, I can't find it. Anyway, so I think about overall in the CKD data, 50% of the patients had a functional fistula at baseline, at start of dialysis, and it was less in the urgent starters, but it was about 30. In my memory, it's about 35 to 40%.
Thank you. And actually, this goes along with a question from our friend Tom Goper. He's asking if the graft placement was actually characterized as a urgent graft placement in the study, or was it elective? Meaning,
no, we do not know whether it was urgent graft. Sorry, it was.
Okay.
We only know whether there is a prosthetic graft or an IV fistula, but we do not know whether for prosthetic graft it was urgent or not. We know the dates. We know the date where it was placed, but we didn't look at it for this paper.
Well, thanks very much. I think we are almost at the top of the hour, and I'll let Bruce make his closing remarks.
Right. Thank you, Roberto. Thank you for leading that session. Thanks to our speakers. Brian, do you have just a quick note on availability of the presentation?
Yeah, we will make this presentation available on our YouTube channel. And in addition, the slides can be made available on request.
Right, indeed, thank you. And then a link to the YouTube channel will be available through our website and also by email that we'll send around in short order. I just wanted to note that we're actually right at the top of the hour, so perfect timing for the 3-hour symposium. Just a very warm thanks again to our study participants, our patients in particular, site coordinators, site investigators, country investigators for all the work that you all have done, giving of yourselves to help keep our program of studies running. And it was just so gratifying to hear today so many speakers from literally around the world speaking to their research. And it's again, incredibly gratifying and so important to us to assure that our data are made available to academic research from really very, very diverse settings, and we're just so appreciative. Quick note, again, hoping everybody stays absolutely as safe as possible during this very difficult time, and with what may be a difficult long number of months coming up over the winter time for many of us. Our thoughts and prayers are with everybody. And lastly, just on a positive note, I hope folks have time to enjoy the ASN Kidney Week, and I very much look forward to hearing some interesting presentations and hearing about truly some exciting developments in the kidney space. So thank you all once again, and have a very good day. Bye-bye.
Hi, goodbye.
Bye. Thank you.